and welcome to today's Public Health Ontario Microbiology Rounds presentation on neonatal sepsis in low-resource settings. My name is Melissa Greenblatt, and I'm a clinical microbiologist at Public Health Ontario and the Hospital for Sick Children, and I have the pleasure of moderating today's session. So before we begin, there's a couple of housekeeping items that I would like to bring up. So the first, the chat pod has been disabled to limit any distractions during the presentation. Also, if you have any questions, please use the Q&A pod during the session. A discussion and question period will also follow this presentation to answer any of these questions. If you experience any technical issues, please email capacitybuilding@oahpp.ca. And lastly, I would like to state that as a moderator of this session, I do not have any conflicts of interest. So it's now my pleasure to introduce the speaker for today's presentation, Dr. Susan Coffin. Dr. Coffin is a pediatric infectious diseases physician who works at the University of Pennsylvania and Children's Hospital of Philadelphia. She has served as a healthcare epidemiologist for several decades, and her research is focused on infection prevention and control and neonatal sepsis in low and middle income countries. I've had the pleasure to work with Dr. Coffin for several years in Botswana and have observed the direct impact she has made on infection control processes at the largest referral hospital in the country. She has been an exceptional mentor for local staff, and it is exciting to have her here today to speak about her experiences in infection control and her research that she's done abroad. So I would like to thank Dr. Coffin for coming, and I'll pass it over to her now.
Hi, everybody. Thanks, Melissa, for that very nice introduction, and I'm really happy to be here. So today we're going to talk about a problem that really exists the world over, but is truly exaggerated in low-resource settings, and that's the problem of neonatal sepsis. What we can see on this chart are the incredible accomplishments that have been made in child survival. The blue represents the proportion of children who survived their first 5 years of childhood. And you can see over on the left hand that back in the 1800s, slightly more than 40% of children died before they reached the age of 5 years. But advancing over to the right, you can say we've made incredible progress globally in child survival, with upwards of 95% of children making it to their 5th birthday. However, all of these issues have not improved across the board. And what I mean by that is that children who are between the ages of 1 month and 5 years have experienced remarkable improvements in their likelihood of survival worldwide. However, our ability to save children during their first 1 month of life really has been limited, and our advances in terms of truly improving neonatal survival have not really been kept pace with their improvements in older children. You can see from this graphic that shows that about half of all under 5 deaths happen in the neonatal period now. That sepsis and other related infections such as pneumonia account for a huge proportion of these deaths. And because most sepsis begins after birth, we think of this as a potentially preventable disease. And we'll talk more about that as this conversation goes on. And so today, what I thought I'd focus on are 3 things. One, what are those drivers that really conspire to make sepsis, neonatal sepsis, such a difficult problem to address, and why it persists despite a lot of efforts globally. We'll talk, since we're in a micro session, about the microbiology of neonatal sepsis. And in particular, I want to share with you some really unique insights that we gained around a cluster of Acinetobacter infections using whole genome sequencing. And then last, touch a little bit on the hopeful aspect of this, which is what are possible interventions that can help us prevent neonatal sepsis. So these are the forces that I think really act in concert to drive this risk of neonatal sepsis. What we see up here is a depiction of a woman giving birth to a baby in a healthcare setting. And that has increased globally by a huge proportion. Now upwards of 80% of babies are born in facilities. And we'll talk more about why that's both a good thing and has caused some new challenges. Next, as a consequence of being born in a facility, a baby is more likely to be exposed to the risk of a healthcare-associated infection. Linked to that, of course, is the risk of that infection might be due to an antimicrobial resistant organism. And then finally, the impact of limited resources, and depicted in this little picture over on the lower right-hand corner, is a depiction of dramatic limitation of actually running water. Here you can see what is essentially a dry sink in the largest NICU in Zambia, and where I've worked. And the way in which running water is provided at times to the NICU is through these buckets with spigots on the top. Clearly not ideal. Data from Botswana have shown us just what a remarkable rate of growth we've achieved in terms of increasing the number of babies born in hospitals, which is fantastic, and it's resulted in a great improvements in maternal survival through the perinatal period. Now, upwards of 90% of all babies in Botswana are born in some kind of a healthcare facility. And you can see that this trend has been occurring worldwide. So this idea of increased babies born in facilities. But why is that a problem? Unfortunately, with the very good intentions of increasing facility births as a way to address issues surrounding maternal mortality, what we've done is grow a care delivery process without expanding the number of sites and the number of healthcare providers capable of assisting. And so we now have a setting in which in many, many parts of the world, the obstetric facilities are just so overwhelmed. There's not enough space, there's not enough providers. And ironically, there is a new risk that's being introduced as a consequence of this overcrowding. One of the things that we have to recognize that, of course, when a baby is born in a facility, there's going to be the same goals for any baby, whether it's born in a high or a low resource setting, to try and address any sorts of problems that babies have, such as prematurity, something like birth asphyxia or a birth injury or congenital anomaly. Again, resulting in a lot more babies, not just who are born in facilities, but who are actually admitted after their birth and have a several day to several week hospitalization to provide care for conditions that if they had arisen at home might not have been able to be addressed. But these increased frequency of prolonged hospitalizations immediately after birth for babies does result in a lot more exposure to the risks associated with hospital stay. And what we'll be focusing on, of course, is the risk of infection. Here you can see just how flat our numbers are in terms of the rate of neonatal infection. You see over on the left-hand side what the rate was in 1990, and over 25 years later, what the rate is in 2015. Absolutely flat. And the little pictures off to the right and left depict really what some of those physical challenges are in terms of resource constraints. Here you see pictures from the NICU I mentioned in Zambia that has a 60 cot capacity. Typical census is 75, and it's not uncommon for there to be up to 90 babies in this 60-bed NICU on any given day. We know that bacteremia, bloodstream infections, and lower respiratory tract infections account for about 80% of neonatal sepsis. So these are the ways infection happen. and that in low resource settings as a whole, almost half of all of the deaths in neonatal sepsis happen to babies who are infected with Klebsiella. And you'll hear this organism come up again and again as we talk through this problem. There are a select number of organisms that really seem to be unusually prevalent in these settings and with these babies. So these are the kind of big players for gram-positive. Staph aureus and enterococcus are the most common causes of neonatal sepsis, with Klebsiella, Acinetobacter, and Pseudomonas representing the most common gram-negative organisms. And I just want to contrast what we see in terms of the pathogen mix in low resource settings to that which we see in high resource settings. Over here on the right, you can see that the little diagram is mostly red. These are mostly gram-positive organisms that are causing risk of bloodstream infection and lower respiratory tract infection in neonates. So something different is going on. We have a different case mix of organisms. What I'm showing you here on this slide is what this can look like. These data are from two different hospitals in Southern Africa. The blue bars are from the hospital where Dr. Greenblatt and I have worked, Princess Marina Hospital in Gaborone, Botswana. And the orange bars are from Tygerberg Hospital in Cape Town, South Africa. And you can see that the pathogen mix, even for these two hospitals, which are somewhat close geographically, are quite different. Princess Marina suffers from a overwhelming predominance of Klebsiella infections, whereas the array of gram-positive and negatives is a little more distributed for the babies admitted to Tygerberg Hospital, who are having as their major problem organisms Klebsiella and Acinetobacter for gram-negatives, and then Enterococcus and Staph aureus for gram-positives. Unfortunately, as time has passed, not only do we have these organisms to deal with, we also have the rapid rise in resistance to conventional antibiotics amongst these organisms. And we know that the rate of rise is incredible. And so this is a projection suggesting that in a mere 25 years, we might see over 4 million deaths attributable specifically to antimicrobial resistant organisms in Africa alone. So really staggering. Although these data are a little bit out of date now, I believe they were gathered from about 2010 or so. They show that the distribution of resistant organisms amongst babies with neonatal sepsis. And you can see that the resistance pattern tends to be for both gram-positive and gram-negative organisms, and reasonably equally distributed, at least as of the time these data were collected. We now know that in Southern African countries, however, that resistant gram-negatives have truly emerged as the group of problem organisms. And while we do have resistant gram-positive organisms, specifically MRSA, it doesn't occur with nearly the frequency that our resistant gram-negatives happen in this setting, nor the frequency that we see MRSA infections in North American settings. What I'd like to do now is change gears a little bit and talk about an interesting outbreak investigation that colleagues of mine did in Botswana in the unit in which both Melissa and I work. And this was in response to a cluster of Acinetobacter infections that had been found in this unit. What you can see are, with the red solid and hatch bars, are isolates of carbapenem-resistant Acinetobacter recovered from the neonatal settings. The solid bars are bloodstream infections. The hatch bars are non-bloodstream isolates. And then the yellow bars represent crab organisms recovered from infections anywhere else in the hospital. You can see that there's a marked change over the course of this year, which is 2021, where early in the year there was an occasional neonatal infection, whereas things definitely changed in the last quarter of the year, where the vast majority of organisms, where the vast majority of crab isolates were from the neonatal unit, and they tended to all be bloodstream infections. So clearly something different was happening. In digging in a little bit, we noticed some very concerning things. One was the really early onset, that cases were emerging with the median age of onset of 4 days, meaning that half of these babies were getting infected before they reached 4 days of age. There also was a greater than 50% case fatality rate associated with this infection. Perhaps not surprising considering just how resistant this organism is, but again, pointing to just how serious a problem these infections can be. So this is the story of the first patient that we recognized and really investigated. So this baby was born prematurely at 28 weeks gestation and was under 1 kilo in weight. On the first day of life, the baby was started on antibiotics. Ampicillin and gentamicin are the first-line antibiotics for neonatal sepsis in the WHO guidelines. And so those were the antibiotics that were started. And the indication was specifically that the clinicians thought that the premature birth might have been triggered by a maternal infection, although there were no overt signs of infection in the mother. And this practice is pretty common if there's an unexplained preterm birth, that antibiotics are started. And I can say that happens in my hospital, and it happens in this hospital where I work in Botswana as well. It's a very common practice. The cultures that were obtained on day 1 of life never grew anything, but the antibiotics were continued because the clinicians were worried that perhaps the organism had been missed for whatever reason. On the 11th day of life for this baby, she started looking a bit sicker, having more difficulty with respiratory status, having some temperature instability, and antibiotics were changed with the concern that perhaps there was a resistant organism, and the antibiotics were changed to amikacin and piperacillin tazobactam, which again are recommended by the WHO as second-line antibiotics to use if a baby fails to respond to AMP and GENT. However, the next day, the blood culture actually came back positive, and this grew a coag negative staph and prompted the clinicians to change to meropenem, which there was questionable data to suggest this isolate specifically was susceptible. However, the baby continued to grow quite sick, and another blood culture was obtained. And finally, on day of life 15, a blood culture isolated a pan-resistant Acinetobacter. So this isolate was a crab, so carbapenem resistant. However, meropenem was used. I believe it was switched to continuous infusion, which is thought to be a touch more effective in the face of carbapenem resistant Acinetobacter. And unfortunately, colistin was not available at that time. So this baby has now been in the hospital and on continuous antibiotics for 2 weeks. And on day 15, we finally have an isolate which demonstrates resistance. And I think the real puzzle is, when did this isolate become pathogenic? And when in this story did this isolate actually change the baby's well-being? And I don't know the answer to that. But what we do know is that this happened while the unit was moving into this outbreak. Investigations were in progress, and our colleagues were swabbing a variety of different surfaces, trying to figure out, was there a contaminated piece of equipment or a contaminated part of the unit that might be better cleaned, better disinfected in order to address an underlying cause of the outbreak. What they found, however, is not that there was one source of the Acinetobacter, but that it seemed to be everywhere. It was on bed rails, it was on the sink, it was on the feeding equipment. There are shared breast pumps in this unit, which are cleaned between use, but obviously not adequately cleaned. And then also, ironically, in the cleaning buckets and cleaning fluid itself. And so as the infection preventionists began to dig in and figure out why is our cleaning fluid growing Acinetobacter, she found that the disinfectant tablets, which are added to water to make an active disinfectant solution, were out of stock, and that the staff was using a dilute bleach solution instead that was made up in a pretty ad hoc fashion, meaning not careful measuring. It was found subsequently, and I'll show you some additional data, that the breast pump that the mother used was contaminated with Acinetobacter, and that the cleaning and disinfectant practices were likely not adequate to get at the part of the pump where the Acinetobacter was growing. This sort of environmental investigation is not something that we do super frequently, at least in my hospital in the US. It's always hard to interpret what it means to recover isolates from the physical environment around a baby, understanding that we don't work in sterile areas. But we thought that in this situation, it was important to really begin to understand where were potential reservoirs of infection, because clearly with the numbers of babies we were having, our efforts to do uniform disinfection of the environment and equipment were not sufficient. And this isn't so surprising. You know, we know that despite the best of intentions, infection control can be really tough, particularly in low resource settings with overcrowded wards. Remember the pictures I showed you of Zambia, and you can see this group of clinicians in the NICU in Botswana. Equipment must be reused that was really not designed to be reprocessed. It's intended to be disposable, but because of shortages and financial constraints, many things are cleaned and reused that weren't intended for that purpose. The laboratory capacity at this time was somewhat limited. They were not yet using a automated blood culture system. There is not a facilitated mechanism for doing organism identification, which they relied on doing biochemicals and benchtop biochemical assays, and they were often out of the reagents, so weren't able to do a really complete biochemical analysis of isolates. And then finally, due to the incredible shortage of healthcare workers and the poor patient to staff ratio, it really just doesn't leave much time in the day for staff to do any sort of routine infection control activities, such as wiping down a work surface, making sure that a respiratory catheter that appears to be contaminated is changed, etc. So one of the exciting parts of our work in Botswana has been able to integrate into a setting in which there are quite limited resources, the selective application of some pretty advanced technology. And in this case, whole genome sequencing, where we were able to partner in this outbreak investigation with a group called Seek Africa, which is a consortium of African laboratories based in Johannesburg, South Africa, that support sequencing of selective microorganisms throughout the southern part of the continent. And our colleagues in Botswana were able to collect and transfer 43 isolates, both clinical isolates as well as environmental isolates, collected around the time of this outbreak in the neonatal unit. So What'd they find? This is a really busy phylogenetic tree, but I think has some really useful information. I'll just orient you to it first. Here, indicated in blue on the diagram are things related to neonates. And you can see cultures obtained from babies are represented by these figures, from an isolate here, hands, and a sink. In orange, you see depicted isolates recovered from adult patients or adult ICU patients if the patient is actually on a bed. And so what the findings were that starting with isolates back as far as March of 2021, we had simultaneously a baby, an isolate, a healthcare worker hand, and a sink, all harboring a very highly related strain, clade of Acinetobacter. And as we analyzed isolates going forward, we found that this specific clade, with oftentimes as few as 2 or less SNP differences, was isolated from many other babies. Then what we noticed is we did not begin seeing a carbapenem-resistant Acinetobacter isolate from an adult that resembled this isolate at all until all the way 12 months later, when it began appearing in a somewhat related isolate began appearing in both ICU patients here, as well as patients admitted to the general medical and surgical wards. One of the most surprising things of all was in August of 2020, now about 15 months after the first isolate from this clade was recovered, there was an adult patient who had a exceptionally highly related isolate as compared to the neonatal isolates. And so this is something we really can't explain, is how and why this one adult patient has essentially the same isolate as recovered from all of these other sites and babies. But I think it's this sort of an analysis that really helps us better understand one of the key drivers, which is persistence of an organism in the physical environment. And through time has led us to find that over and over again, the sinks seem to be highly suspect in terms of being a reservoir of organisms. Oops. So last, to change gears, I want to talk a little bit about something more optimistic: prevention. Prevention can make a difference. And so this isn't all a story of doom and gloom. One of the things we do know that our work to prevent HAIs will also prevent antimicrobial resistance and vice versa. We know that these days, HAIs, or healthcare-associated infections, can be caused by resistant organisms in about 80% of episodes in some settings. Here you can see in the panels different antimicrobial susceptibility patterns of both Acinetobacter and Klebsiella, and so obviously pretty frightening isolates. And then also these data have been replicated in both high and low resource settings. There is a markedly increased risk of death to a patient if their infection is due to a resistant version of an organism versus a susceptible version. And this is true whether we're talking about a resistant Klebsiella, a resistant Acinetobacter, resistant Staph aureus. The mere presence of resistance makes the risk of death greater. Given all of these issues with persistence of organisms and resistant organisms in the physical environment, I think studying the modes of transmission and the transmission pathways has become really important to those of us concerned with neonatal sepsis. We are slowly recognizing that we are unlikely to be able to eradicate these organisms from the patient care environment. And so our capacity to block spread from the environment to a patient, from the healthcare workers to a patient becomes all the more important because these bugs appear not to be going anyplace. So here's a list of different things that are in the WHO's recommended guidelines for how to prevent CRE or infections due to carbapenem-resistant Enterobacteriales. Hand hygiene, environmental cleaning, contact precautions, isolation, surveillance, and then monitoring, auditing, feedback of data. So as we talk with our colleagues and work with them on these issues, what we know is that some of these things just don't work. We know that very few settings have a luxury of space that would allow them to do isolation, whereas most sites that I've worked with acknowledge there are opportunities, and probably pretty significant ones, to improve hand hygiene. I think the jury's out a lot on how best we can improve environmental cleaning, whether we should be pushing for the use of contact precautions when someone's got a infection with a resistant organism, the capacity to do traditional, highly detailed surveillance for either colonization or clinical infection due to resistant organisms, and whether or not we can develop robust enough data streams to have a real monitoring, audit, and feedback process. One project that I had the good fortune of being involved with was a project in Zambia in the NICU that I've alluded to previously, and I did it with these two individuals, David Hamer and Lawrence Mao-Chanda. And so what we did there is an observational study looking basically at the capacity to change the rate of neonatal sepsis by implementing a not very fancy bundle of activities. And they really included some simple things. There's training of the staff in the neonatal unit, as well as labor and delivery, which we thought was really important given how early onset some of these infections were. Introducing a local production of alcohol-based hand rub, so they weren't reliant on the supply chain and the purchasing capacity of their hospital. Doing a weekly bathing with a skin antiseptic called chlorhexidine, and this is for all babies over 1 kilo. Working with the cleaning staff at this hospital to try and focus their efforts on the sites most likely to be contaminated, and really enhancing the ability to at least reduce the magnitude of the reservoirs. And then finally, using simple SMS messaging to remind staff on a daily basis of some basic hand hygiene and other infection control principles. So this is what our study looked like for the course of about 2 years. We recruited almost all the neonates who were born and admitted to this NICU. We interviewed their moms and reviewed the medical record. And we did blood cultures on all babies if they had clinical sepsis suspected. And we used typical clinical indicators for sepsis. What we found is that there was an exceptionally high rate of clinical sepsis, meaning a baby who had tachycardia, hypotension, or temp instability. And that of those babies who had a clinical picture of sepsis, 40% of them had a positive blood culture. And the majority of those blood cultures, almost 80% of those positive blood cultures, isolated a true pathogen, meaning not a single culture positive for something like coag-negative staph or staph epi. What we then did is look at our observations based on the time of the study. So first, examining the baseline, you can see that about a third of babies went through their neonatal stay without getting infected at all. That's the blue bars, whereas 2/3 had either culture negative sepsis, represented in orange, infection with a pathogen, traditional pathogen, isolated, in gray, or a bloodstream infection with a skin commensal isolated. We then, as I said, introduced this simple bundle, and we're able to see a pretty marked difference. We went from having about 1/3 of babies to almost 60% of babies get through their NICU stay without having any sign of sepsis, which was a huge improvement. There was a somewhat similar number of babies who continued to have culture negative sepsis, although sepsis due to a pathogen and sepsis or bloodstream infections due to pathogen and bloodstream infections due with a commensal isolated were also reduced. One of the most exciting aspects of this study was our capacity to change the pattern of mortality that this unit had experienced. And so here you can see that over on the left-hand side of the graph, mortality is not a static number in this unit or in many units. There seem to be seasonal stresses that increase the likelihood of mortality, and we don't fully understand what that's about. However, after implementation of our bundle, we were able to smooth this line and avoid some of the undulation associated with the highest risks of bloodstream infection. And again, unfortunately, our funding stopped, and we don't have data that extends beyond this to know how well these improvements have been able to be sustained. But anecdotally, we hear that the unit continues to have episodic outbreaks, perhaps at a lower frequency than they used to. So we're eager to get back and continue to work with our colleagues there. Our analysis then focused on what were the things that were most associated with a death in a baby who had sepsis. And here you can see that the overwhelming driver was, in fact, Klebsiella infection. And so very high case fatality rate, or attributable case fatality rate, on the order of what we've described elsewhere. And virtually all of these isolates were resistant to beta-lactamases. So again, proving hard to treat in this setting. Birth weight was protective, meaning the bigger the baby, the lower the risk of infection. And this is something which has been well described in virtually all settings, is that for somewhat obvious reasons, big babies are at an advantage. So through this talk, what I hope I've been able to share with you is that the problem of neonatal sepsis in low resource settings is really driven by unintended consequences of advancing neonatal and maternal perinatal care. And that we now need to turn our attention to this this major unintended consequence. Neonatal mortality due to sepsis is strongly driven by the causative pathogen and its antimicrobial susceptibility pattern, and also that the promise of new microbiological techniques really may bring an advance in our capacity for early recognition and response to emerging outbreaks. And then last, that prevention is possible, but it requires resources and a lot of dedication. And so with that, I will stop and make sure to thank the many, many people who've been involved with this work. I'm sure there are many others that have been critically involved that I've forgotten to put on this slide. And then our funders who have also contributed to allowing us to do this work. And then with that, I'll end and turn it back to Melissa.
That was an excellent presentation. Thank you, Dr. Coffin. We will now move to the Q&A segment of this event. So if you could please put any of your questions in the Q&A pod if you have not already done so, that would be greatly appreciated. I think I'll start off with a question myself. So one thing that I'm really interested in is, I feel like in kind of what we consider to be our high resource settings in our urban centers in say downtown Toronto in North America, or maybe in Philadelphia for yourself, we might feel that we are doing a pretty good job sometimes with our infection control. But I wanted to get an understanding if there's been any lessons that you've learned from working in the settings that you have abroad that you've actually been able to bring home to North America to improve infection control practices.
Yeah, there definitely have been. I think a couple of them center around hand hygiene, and knowing that one of the very biggest challenges to hand hygiene is having alcohol hand rub really close to where you're examining a baby. And we've been able, in certain settings in which I've worked, to put alcohol hand rub hanging on the end of the isolette or the crib of a baby. And with that, been able to really drive up the frequency of hand hygiene occurrences. And I've taken that back to my hospital in Philadelphia and said, please, can we have a portable hand hygiene dispenser at every single bedside in this. And I think that has been a really nice example of learning from a low resource center and moving to a higher resource center that's made a difference. The other thing, which has been a big eye opener for me, is the role of the physical environment and of hidden reservoirs of organisms in driving infections. And, I shared with you this dramatic story of the crab outbreak and its reservoir in the sinks. But over the past year or two, there have been several really dramatic reports from high income settings describing outbreaks also related to sinks. And so I think this idea of water and the benefits and the risks of having water so close to healthcare are just beginning to be understood. And our experiences in low resource settings, I think, are telling us we need to be much more suspicious of this in our high income settings too. So those are two different things that I think have been big and important learnings for me.
Those are great points, and I always think that these partnerships they're very much a two-way learning, and not only can we be mentors based off of our settings, I feel like there's so much that we can learn from the settings that we're participating and partnering in as well. So I love that there's been lessons learned that you've been able to take back to Philadelphia as well. Yeah. Surrounding that context of having the sources of water close to patient care and kind of the benefits and also the challenges that surround that. You talked a lot about Acinetobacter in your presentation, but you also had Klebsiella showing that being one of the leading cause of sepsis. So I was wondering, in addition to Acinetobacter, where you talked about a lot of that environmental contamination, has there been any investigations for Klebsiella in the settings that you've worked in, where are potential sources that may have come from as well, and kind of what interventions were able to have taken place as a result of those investigations?
I think it's easier to respond to like what investigations have revealed, and they're definitely in basically monthly or every other month sweeps of the built environment of the neonatal unit. Our collaborator who lives and works in Botswana, Jonathan Strisco, swabs and unfortunately finds both Acinetobacter and Klebsiella in sinks, sink drains, on equipment used to mix formula, in respiratory care equipment. And one of the common themes of this is all water and wetness. And it turns out that those sorts of environments favor both Klebsiella and Acinetobacter. And why we see these waves where first it's Klebsiella and it's all Klebsiella all the time, And then we go through a phase where it's Acinetobacter and all Acinetobacter all the time. We don't yet understand. The challenges are the places where these organisms are hiding out are really hard to clean and disinfect. Like you can't take apart all of the plumbing of a of every sink within the neonatal unit in Botswana and install new plumbing. Some people have actually tried that, and what they've demonstrated is that at the juncture where the new plumbing meets that old plumbing, you start that migration, that kind of crawling of biofilm and organism. And so that typically within a month or so, your new piping is similarly contaminated. And so I think that the likely approach is going to have to be some sort of regular maintenance function where we do weekly, monthly disinfection of the entire outflow system of a sink, trying to keep biofilm and the infected, organisms integrated into it down to the very lowest capacity. But we don't really know how to do that yet. We're just starting that work.
Yeah, and it's very complex. I remember Dr. Strisko, another finding that he had from doing his swabbings in the unit was that there was actually, I think he swabbed a bug that had been
that is
around.
correct.
And he also found that it was positive. I think it was for Acinetobacter.
That one, our fly had Klebsiella on it, I believe.
The fly had Klebsiella, yeah. So many interesting places where you can find these drug-resistant organisms as well. There's definitely questions in the Q&A pod, so I want to make sure that I turn to those as well. So our first question, there is some interest in understanding a little bit more as to whether you've done any investigation for viral pathogens that are contributing to neonatal sepsis.
That's a great question. I personally have not participated very much at all in work like that. The focus has been pretty tightly on bacterial and to some degree fungal pathogens, but I think there's a whole big world out there of viral healthcare associated infections in neonates that we need to better understand. And COVID has given us the signal worldwide that these are happening. And we know things like RSV and rhinovirus also can easily be passed from adults in the unit to neonates and cause bad outcomes. The sites that I've worked with typically do not have any viral diagnostic capacity. And so it would take a infusion of academic money and effort, I think, to answer some of those important questions.
Yeah, and I agree. Similar to myself, that most of the sites that I've worked at don't have that molecular capacity to do viral diagnostics, and certainly I think it would be close to impossible to do a viral culture in those settings too, and really having the basics for routine bacterial diagnostics, which, as you mentioned in the presentation as well, it has been challenging in Botswana. And I feel that that's a lab that's quite far advanced for those settings as well. Another question that we have in the pod is, how do we approach making a diagnosis of culture negative neonatal sepsis in resource limited settings using diagnostic criteria that can be applied consistently across countries or sites and do not lead to over or under diagnosis?
Great question, and one that's plagued all of the work on this topic that I've done, which is very few units have continuous monitoring, and the staff to be able to detect immediately after onset an episode of tachycardia or potentially hypoxia. And so we suspect we have dramatic underdetection of physiologic criteria that would map to neonatal sepsis. And so we recognize that our estimates of the frequency of clinical sepsis are probably low. And similarly, it's possible that our estimates about the proportion of clinical sepsis caused by pathogens may be a little bit inflated because of that, because we're perhaps more likely to detect a baby who's gotten a bit worse and stayed worse for a longer period of time. And so there's a little bit of an ascertainment bias going on there. That said, when we've done analyses using denominators such as patient days, the burden of the problem remains large. And several studies, the Zambian study included, are able to demonstrate improvements using a denominator such as patient days, which takes out that kind of subjective and inconsistent application of the use of clinical sepsis as a denominator.
Thank you. Another question, and I had this one as well. So you see quite a difference between having the gram positives that will predominate in the high income countries, whereas in the lower income countries, you're seeing more of the gram negatives involved in neonatal sepsis. So in particular, there's an interest in understanding related to GBS.
Mm-hmm.
And so the question is whether GBS is usually screened in low and middle income countries or empirically treated peripartum, and do we expect differences in colonization rates?
All great questions. I can tell you a few little things that I know about GBS in low resource settings. One is that very few middle and even fewer low income settings I know have any sort of standardized approach to GBS screening of mothers. Studies that have been done both in Botswana and the Dominican Republic by a colleague, Dr. Adam Ratner, who's at NYU, have demonstrated relatively high rates of carriage of GBS. I think on the order of about 15% in Botswana and approximating 35% in the Dominican Republic, which is amongst the highest in the world. Unfortunately, limited capacity of blood culture systems. And many settings do not yet have automated blood culture systems, and even on a more basic level, do not have blood culture bottles continuously available. And so I don't think we really know what contribution GBS plays to the true array of pathogens causing neonatal sepsis. It is interesting that it is very, very rarely isolated for a variety of reasons, whether it's microcapacity, perhaps really aggressive use of ampicillin for almost all babies who get admitted to a neonatal unit for the first 2 days. I'm not sure, but that's really good work that we hope somebody will be able to do soon.
Thank you for sharing your thoughts on that. And then there's a couple of questions related to antibiotic resistance that the group wanted to ask as well. So are there resistance rates in neonatal infections comparable to the resistance rates seen in adults in Botswana?
That's a good question. My perception, and I can't really conjure up a specific paper that demonstrates this, and speak up, Melissa, if you have it, is that there is a higher prevalence of carbapenem resistant organisms in our adult patients as compared to our neonatal patients, but that the vast majority of infections in adults and babies, children, are, if they're gram negatives, they're caused by ESBL producing organisms.
And I don't know the neonate data very well in Botswana, but definitely that there's very high rates of ESBL and pretty high rates of just a patient colonization of individuals coming into Princess Marina, and then also from the community as well, very high rates of ESBL and carbapenem resistant enterobacterales too. But again, I don't know the difference of what we see between the neonates and the adults. And then another good point that has come up in the chat. So the resistance of gram-negative predominance echoes findings in several low and middle income settings. Is it time, and I thought it was good related to some of the work that we've been doing too recently, is it time to change the AMP and GENT as empiric antibiotics for neonates? And if so, to what, and to what cost of driving further resistance?
It's perfect, completely on target questions. I think the first part of the question is easy. Yes, it's time. The to what question, I think my interpretation is there is not one single answer, and there probably should not be one answer. What I think we're learning is that there is a real local component to the antimicrobial resistance pattern seen in specific parts of the world. For example, the unit that I've worked with in Botswana is about 4 hours from probably the largest unit in South Africa that's in Johannesburg. And I just had a chance to meet with the director of that unit just yesterday. And they have about 60% of their bloodstream infections being caused by carbapenem-resistant organisms. They have a very healthy amount, unfortunately, of Candida auris. And so even with just a 4-hour difference and a population that moves somewhat freely across the Botswana-South Africa border, there's very different resistance patterns. And I think that's going to make it really challenging to come up with what would be ideal, which would be truly local antibiograms, local data to drive empiric prescribing.
There's still so many great questions in the chat, but I see that we're starting to run out of time. So I just wanted to quickly ask this very last question, because I do think it's a really important question every setting that you kind of jump into to partner with. So the question is, were there challenges to obtain buy-in or participation from local groups when suggesting some of the IPAC practice bundles? And if so, how were the local groups engaged?
I think the answer is always yes, and it always needs to be a situation in which an outside group, such as groups I've been involved with, has funding, and that's an incredible power to come in and meet with and learn what are problems, whether or not your ideas are the right ideas, of questions that need to be answered, and to be humble and willing enough to suggest redirection. We've been lucky, I'll say this for you as well, Melissa, in that the site we've worked in Botswana has a long history of partnership and pretty successful partnership with University of Pennsylvania Hospital. And so there has been, over the course of decades, growing trust and real research resources that are based in Botswana, staffed and directed by Botswanans, that drive much of the research infrastructure there. And then if Melissa hasn't already given a talk on her work, in terms of building micro capacity there's some really lovely work that she's involved with, really helping expand the resources that local experts have to be able to use their expertise to the fullest extent possible. Because oftentimes it's a resource, not an expertise shortage that is the problem.
And I just wanted to add before we close up, I think it's really great how you mentioned it, and it's one thing that I've noticed working with the group in Botswana as well, is that the project is driven by locals. They're the ones that kind of express their needs, and it's really, I feel it's truly a partnership, and it's never been kind of going in and these are our goals and these are the strategies we're going to use. I feel that it's always been a partnership, and that it's the role that Penn and others have played in Botswana has been to act as more of a support and of sharing resources and knowledge. And those projects are led by individuals who reside and work in Botswana. And I always have felt that that's been a great strategy. And I think that's why that partnership has been so successful.
Yeah. And makes it just plain old fun too.
Yeah,
you have,
exactly.
Good professional relationships and great friendships that come from it.
Exactly. So I'm just going to close off this session now. So as we wrap up today's PHO microbiology rounds, I'd like to thank Dr. Susan Coffin for presenting, and I would also like to thank everyone who joined us for today's webinar. You can expect to receive a brief and anonymous PHO micro round survey for today's session. Please try to complete this to help us improve our programming. And a reminder to everyone to save the date. Topic: the Ontario Public Health Convention will be held on March 26th until April 23rd in 2024, and it's now accepting abstract submissions for the program. So please check out those details on the website. Lastly, to access PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you everyone for joining, and have a wonderful day.
Thank you.